Good evening. I'm Dr. Monisha Arlalan. Today I'll be discussing the recall questions of the INI-CET 2022, all the obstetric questions. Coming to, since this is a recall questions, it is not going to be 100% perfect. Today we'll be discussing all the obstetric questions, and surprisingly this time the exam had a lot of obstetric questions. And to talk about the difficulty level, some questions were easier questions and most of them are very difficult, and all were the PG level questions were asked, and most of them were directly from the Williams. And so without wasting much time, we will see what is the questions that been asked. We'll start with I started with a very easy question to feel good. That is, all these investigations, the first questions are, all these investigations are cost-effective screening test, which is done routinely in pregnancy. So the options are bacteria, VDRL for syphilis, echo, and screening for diabetes mellitus. So this is an easier question, as I said. So the antenatal screening, when the patient comes for the first antenatal visit, it is also called a booking visit. You will do, we will be doing a hemoglobin, a blood grouping and typing of the patient to see if she is whether she comes under Rh negative pregnancy, and we'll do a serological markers like HIV, HBsAg, and VDRL for syphilis, which is, and HCV is also done nowadays. And other is the urine routine and microscopy and culture, that is to rule out any asymptomatic bacteria that is present. Then and we'll also be doing a pap smear. The important, so the question that was asked is, all these investigations are cost-effective screening test that is done routinely in pregnancy. So bacteria, we are doing the urine routine, microscopy and culture. So that is the right answer. VDRL for syphilis is the right answer. Echo is not done regularly. Whereas auscultation is very important in case of all pregnant women who are giving especially in the booking visit. And screening for diabetes mellitus, as we are ethnic, for that is a high risk group, so it is important that we screen for GDM in their first visit. Coming to the next question, which is incorrect regarding the pathogenesis of preeclampsia. Okay, so this exam also had a lot of medical disorders of pregnancy. So very important among this is diabetes and hypertension. So they've asked about preeclampsia, that is especially pathogenesis. Your first option is angiogenic factors play an important role, and in preeclamptic women there is increase in this SFLT, that is soluble FMS like tyrosine kinase, and decrease in the PIGF, that is platelet and bit growth factor. So next is vasoconstriction leads to ischemia, necrosis and hemorrhage and end organ damage seen in the preeclampsia. So that is also a right answer. Endothelial dysfunction. So preeclampsia, the Q word for that is endothelial dysfunction. So here they started with an endothelial dysfunction that has leading to reduced nitric oxide level. So nitric oxide, which is a vasodilator, so it is right. It leads to reduced nitric oxide levels, and this causes the clinical presentation of preeclampsia. That is also right. Coming to the next option, prostaglandins play an important role. There is decrease in the thromboxane A2 and increase in the PGI2 levels. That is the ratio. Prostaglandins I2 and thromboxane A2 ratio in the preeclampsia, whereas PGI2 is a vasodilator, where thromboxane A2 is a vasoconstrictor. So the ratio decreases in preeclampsia. So the option will be option D will be the answer. So all the pathogenesis that I've described, first three options are right. So coming to the pathogenesis, very briefly we'll be discussing, will not go in depth. So there is an imbalance between the angiogenic and the anti-angiogenic factors. So that is the main pathogenesis in a preeclampsia. Another Q word to remember in a preeclampsia is endothelial dysfunction. So vasoconstriction, why there is a vasoconstriction? So there is all the vasodilator levels decreases, that is decrease in nitric oxide levels, and it and also the prostacyclin levels, and increase in the endothelin thromboxane A2 levels, which are vasoconstrictors. So this is a chart that is the pathogenesis has been described very beautifully in this chart. So we have to know all that is most commonly they'll be asking this. So remember, this is the soluble SFLT that increases, and VGFR, that is endothelial growth factor, that also increases, and all the vasodilators level decreases in case of preeclampsia. So that is the main pathogenesis in case of a preeclampsia. Now, this is a really tough question that has been asked this time. Even the PGs will be answering this. The Saglat procedure that is not done during pregnancy is. So, Sarklaj, we will most be reading only about the Shirodskar method, modified Shirodskar method, but this is a little different and kind of interesting question here. It is not done during pregnancy. So, how it is classified? So, during pregnancy and non-pregnant stage. So during pregnancy, it is the under that it is transvaginally or transabdominally the surgeries have been done. Transvaginal, which we know about it, is Shirodskar modified modified way is the McDonald's. Shirodskar modified, that is McDonald's. Another one is called the worm procedure, worm or Hefner's. Here, this is done in a very advanced stage, that is, there is cervical dilatation with the bulging membranes. So this is one procedure, but I have not seen this procedure till today, but previously it has been done. Worm procedure, it is also known as the Hefner procedure. Next is the transabdominal procedures. Under that you have, at least remember the names. So the questions, when they ask this kind of questions, you will be able to answer. So transabdominally, remember the names: Benson procedure, Novi procedure, Maran procedure, areas. So these are the procedure that has been that is done transabdominally. Non-pregnant, remember the lash, man, ischemic. Another one is called the page. So this is done in a non-pregnant stage. And where is it done? If it is a severely lacerated cervix, and this is a permanent procedure, so delivery will be only by a cesarean section. So the answer for this question will be the Sarklaj procedure not done during pregnancy. The answer is lash. Laparoscopically also it is done, that is transabdominal procedures can be done laparoscopically even during pregnancy. Coming to the next question. Okay, this is also a very interesting question, which is incorrect. See, again, this is a medical disorder question that is again from a preeclampsia. So diabetes and hypertension are a very high yielding topic. So make sure that topic will be thorough next time when whoever is preparing. So which is incorrect regarding the magnesium sulfate in preeclampsia and eclampsia? Yeah, first option is it is an anticonvulsant. Yes, it is right. Or it has an anticonvulsant effect on the cerebral cortex and simultaneously lowers the BP. The first part of the answer is right. It has an anticonvulsant effect on the cerebral cortex is right. Next, we will see that simultaneously lowers the BP. So we will keep this. We'll go to the next option. Maintenance dose is given for 24 hours after delivery or in the event of the postpartum seizures. It is given for 24 hours after the last seizures. So that is also a right answer. Next is magnesium sulfate quietens that it decreases the uterine activity, or it has a tocolytic kind of activity, and this action is a dose dependent. Yes, that is also a right answer. Magnesium sulfate is entirely excreted by the kidneys, hence the initial loading dose to be given irrespective of the renal function, but maintenance dose has to be titrated as per the GFR. This is also a right answer. Remember, the each and every sentence are taken from the Williams. It is reproduced, same sentences has been asked as an options. So we'll come to magnesium sulfate. We'll have a little knowledge of this. So drug of choice for severe preeclampsia with imminent symptoms. or imminent for eclampsia. So magnesium sulfate is not given to treat hypertension. This is how it is given in Williams, in italics. So this is important. So it is not used to reduce the blood pressure. It is given as an anticonvulsant. What is the mechanism of action? It blocks the NMDA receptors that is present in the cerebral cortex. Plus, it also has a vasodilatory effect. It is given mainly it is given as IV and IM routes. And remember, it is completely excreted by the kidneys. That is a very important point. And very, very important point is the magnesium to be continued 24 hours postpartum or 24 hours from the last seizures. That is another point that is also asked as a question. Then before giving, you have to monitor, see whether the patient has an adequate urine output, at least 30 ml per hour, that is, she is not oliguric. Next is a deep tendon reflexes to be present, and the respiratory rate should be at least more than 14 per mm, and pulse oxy, that is, there is saturation levels of more than 96. Coming to the therapeutic range of this magnesium sulfate is between 4 to 7 milliequivalents. An antidote for this excessive toxicity is 10% calcium gluconate or the calcium chloride is being used. Next. So coming to the toxicity, so the first sign that we say it is magnesium toxicity has come is the one is the disappearance of the patellar reflex. The dose it exceeds of 10 milliequivalents per liter. Similarly, if there is a respiratory, initially with that 10 milliequivalents, there is respiratory depression. Only when there is 12 milliequivalent that goes into respiratory paralysis. There is a one more option that was given. Next is the magnesium sulfate decreases the uterine activity. Yes, it is acting as a uterine tocolytic, more like a tocolytic kind of action, and this action is a dose dependent, and this action is seen when the dose is between 8 to 10 milliequivalents per liter. And the last point is exactly from the Williams. It says that it is excreted entirely by the kidneys. Yeah, I have already told that. So the whatever the initial dose of magnesium, according to regimen, whatever regimen you're giving, loading dose will not be altered. But the maintenance dose, whatever you're giving, maintenance dose that we are following up to 24 hours should be titrated according to the GFR. So that is a very important point to be kept in mind. Next question is, which is not included in the diagnosis of preterm labor? This is a very direct question, not to worry much. It's a very easy question. Preterm labor, that is onset of labor before 37 weeks. So here you have a contraction, at 8 contractions in 60 minutes or 4 contractions in 20 minutes with 80% of cervical effacement of more than 1 centimeter cervical dilatation. That is defined as a preterm labor. Now coming to the question, so which is not included in diagnosis, cervical dilatation of more than 1 centimeter is the right answer. Cervical effacement of more than 80%, 4 contraction 20 minutes and 8 contraction in 60 minutes, and cervix is always central or posterior. So that is the wrong answer. So that will be the not included in the diagnosis. Next question is, this is also a very tricky question, and not much knowledge is on which we usually don't get this kind of question. Yeah, we'll see the question. A woman who has been taking tamoxifen following breast cancer treatment. So she has been taking tamoxifen for breast cancer for a period of 5 years. Now the patient wants to conceive. After how many days of stopping of tamoxifen can she conceive? So the given continued tamoxifen can conceive immediately after stopping, within a month or 3 months. So we'll see a little, should have a little knowledge to answer this question. So tamoxifen is a selective estrogen receptor modulator, and conception should be delayed for 2 to 3 years. And why? Because the recurrence rate is very high. Pregnancy again, which has a high estrogen levels. Next, increased progesterone levels. So that is a problem there. Another one is, what is the method? Here you cannot give a hormonal contraceptive in case of a breast cancer. So contraceptive of choice here, it will be a intrauterine copper containing intrauterine devices. And tamoxifen, tamoxifen gets it has a long half-life and it is highly teratogenic. So therefore the pregnancy should be delayed up to 2 months of stoppage of the drug. That is what is given according to the Williams. The answer is 2 months. That is after stoppage of 2 months they can conceive. But the guidelines, that is RCOG guidelines, say it is 3 months. So we will go with our Williams only. So the answer will be 3 months. Williams answer is not here. So we'll go with the RCOG guidelines. That is 3 months will be the answer. Coming to the next question. A 37-year-old female who is unmarried is on OCPs. She is sexually active. She visits her gynecologist for her routine screening. Her mother had breast cancer at 55 years and her sister had ovarian cancer at 40 years. What will you advise her? Whether you will advise her a prophylactic surgery. See, mind it, you have to see the age of the patient in this type of questions. Look, she is 37 years and still she is unmarried. So prophylactic surgery, that is one option they have given. To stop OCPs, the second option, mammograms every year, and the last option is the genetic testing and BRCA, that is BRCA testing. Here they have mentioned that her mother had breast cancer as well as her sister had an ovarian cancer at a very early age. So it is important you do a BRCA testing. Here, when you do a BRCA testing is that before doing a BRCA testing, you should know that BRCA1, it has a 40% risk of an ovarian carcinoma, whereas BRCA2, that is BRCA2, has a 20% risk of developing a ovarian carcinoma. In a families with a first degree relatives, the risk of female with the first degree relating having affected gene could be as high as 35 to 40%. Similarly, the women who appear to be at a higher risk for an ovarian or a breast cancer should undergo a genetic counseling, and if risk is substantial, offer a genetic testing for the BRCA1 as well as for the BRCA2. So as I told, she's 37 years and still she's unmarried. So preservation of fertility should be there. So we can advise them to do a transvaginal ultrasound every 6 months, which is not given in the option. But remember, this will be the option. Genetic testing and BRCA is a very clear-cut answer because she have a history, that is family history of both the breast cancer as well as the ovarian cancer. So she's at a very high risk. OCPs, they're talking about stop OCPs, but OCPs are recommended in this high risk women and who do not wish, she has conceived, she has married, conceived, have kids, and who do not want to preserve fertility, advice for prophylactic bilateral salpingo-oophorectomy, that is after 35 years of age. So that is one way. And BRCA testing criteria is if you have a family history of a breast cancer, ovarian cancer, history of breast cancer in the close relative less than 50 years, or the first or second degree relative with a known BRCA mutation. So we will advise them to do a genetic testing. Coming to the next question. So which is incorrect regarding acute pyelonephritis? Yeah, this is also again a straightforward question directly from the Williams. Each word has been repeated again as options here. So what is incorrect? So to that, there's a table that is given in Williams which says the management of pregnant women with acute pyelonephritis. So a patient comes with acute pyelonephritis, hospitalized, obtain a urine and possibly blood cultures too, and evaluate the hemogram, serum creatinine levels, electrolytes, and monitor the vital signs frequently, including the urine output, and establish the urine output of more than 50 ml, and you have to give an IV crystalloids can be given. Administer IV antimicrobial therapy. obtain a chest radiograph if there is a dyspnea or tachypnea, repeat hematology and biochemistry studies in every 48 hours, and change to oral antibiotics when they are afebrile, and discharge when afebrile for 24 hours, and consider an antimicrobial therapy for 7 to 10 days, and repeat urine culture 1 or 2 weeks after the antimicrobial therapy is completed. So this is the table that is given in the Williams. So that has been asked our options. Now we will see with a question. The question is which is incorrect. So first option is oral antibiotics once afebrile. That is true. Hospitalize and urine and blood culture. That is also right answer. Next is maintain a urine output of more than 50 ml per hour. That is also right answer. You given IV crystalloids can be given. The option is discharge if afebrile for 72 hours. Continue antimicrobials for 5 days. That will be the wrong answer. The answer was discharge when afebrile for 24 hours will be the right answer. And you give the antimicrobials for 7 to 10 days will be the answer. Now coming to the next question. So as per WHO SAGE guidelines, the recommended dosage of HPV vaccine in 9 to 14 years. This is again a very difficult question. See, this guidelines, new one has come only recent. This is in April 2022. This WHO SAGE guidelines has been given. So that is SAGE, Strategic Advisory Group on of experts on immunization. So first we'll let us know what is the normal one. See, HPV vaccines, what we were giving, there were 3 vaccines. That was the 2 vaccines that is available in India, and the 3rd vaccine still not available in India. Available, that is the bivalent Cervarix vaccine, which contains HPV 16, 18, and which is given as 3 doses in the interval of the 0, 1, and 6 months. And the next vaccine that is available, which is Gardasil, which is a quadrivalent, where it contains HPV 6, 11, 16 and 18, and it given as 2 doses, or it can be given as 3 doses. When it is given as 2 doses, 0 and 6th month. When it's given as 3 doses, it's 0, 2 and 6. The vaccine that is not available in India, that is Gardasil 9. There you have 9 variants of HPV, which includes the 6, 11, 16, 18, 31, 33, 45, 52, 58, and remember this also is given as a 2 or 3 doses. Now, what is the change that they have got by this strategic advisory group of experts is that says that they recommend that the updating the dosage schedules for HPV, that is 1 or 2 dose schedule for the primary target of girls aged 9 to 14 years, 1 or 2 dose schedule for the young women aged 15 to 20, and 2 doses with a 6-month interval for a women older than 21. Basically, they wanted to reduce the make it a single dose schedule, provide comfortable efficiency comparing to the 2 or 3 doses. That's what they say. That is, they want to make it a single schedule doses, and they have told that there is a comparable efficiency between 2 or 3 doses that we are giving now. And we all know that HPV vaccine is highly effective in the prevention of HPV serotype 16 and 18, which causes 70% of the cervical cancer. This is the new change that has been brought only in April 2022. Okay. Next question. This is a easier question, so I'm not going to explain much. So, which of the following is caused by HPV high risk type? Which is of the following is caused by HPV? Sorry, the question is wrong. It is not caused by HPV high risk type. So answer is the laryngeal papillomatosis. As we know, other things, high risk type, it causes cervical, anal cancer, oropharyngeal cancer. I'm not discussing much about this. It's a direct question. Next is Which of the following is associated with Kalman syndrome? Which of the following is associated with the Kalman syndrome? There's a white forelock or a syndactyly anosmia precocious puberty. So these are the options. Which is associated with that is answer will be anosmia. This is also frequently asked question. We'll see what is it. Kalman syndrome, briefly we'll see, it is also known as de Morsier syndrome, triad of hypogonadism, anosmia and color blindness. So here it is maybe associated with the midline defects. So what were the options given? Syndactyly is not associated, but if they give a cleft palate or cleft lip, so Kalman syndrome associated with cleft lip, cleft palate, and also with the cerebellar ataxia. So that is one of the anomaly or a defect that is seen in a Kalman syndrome. Then they have also given about the precocious puberty. That is a wrong answer. See, in Kalman syndrome, the defect lies at the level of the hypothalamus at the arcuate nucleus. So the GnRH is not secreted properly. Here they will present with a delayed puberty. How will you differentiate between a Kalman syndrome and a constitutional delay? In Kalman syndrome, there's a normal height. So they present with normal height. And there's one more option that was there, that is a white forelock. So white forelock is seen in a syndrome called the Waardenburg syndrome, which is a genetic condition that has components like hearing loss and change in the coloring, the pigmentation of the hair, skin, and eyes. So that is Waardenburg syndrome. The syndactyly is not associated with Kalman syndrome. Remember, it is the midline defects has been associated with Kalman syndrome. Anosmia is the option, right answer, and precautions, it's a delayed puberty that is associated. Next. Again, this is a very difficult question. Letrozole, where we will be knowing a lot about a letrozole, but the problem is that T-half, those things we will not concentrate much about it. But the answer here, it is 3 to 4 days, so the answer will be 90 hours. We'll have a small brief idea of this. Letrozole, we know it's an ovulation induction. It is used for postmenopausal breast cancer. It is also a drug of choice in ovulation induction in PCOS patients. It is an aromatase inhibitor. So aromatase enzyme is a rate limiting step in the synthesis of estrogen. And the half-life is 3 to 4 days. That was a question asked. So 90 hours is the answer. Next question is, which is incorrect regarding the diabetes in pregnancy? One is the elective LSCS does not increase in incidence. So elective LSCS does not increase in incidence. Does not decrease in the incidence of the brachial plexus injury. Another one is in the active labor. If the RBS is less than 70, you have to give a 5% dextrose started at the rate of 100 to 150, and till the RBS is reached up to 100 milligrams. Next option is in a patient being planned for induction of labor. Planned for labor, her night dose, if intermediate insulin, is given as planned, and the morning insulin dose is also given. Next option is capillary blood glucose monitoring levels are kept at fasting as 95, 1 hour is 140, and second hour is 120. So first option, if you see in Williams, it says that there is very insufficient evidence suggesting that the elective LSCS will reduce the risk of birth injuries. So that is the exact wordings from the Williams. So the answer is it might decrease, but there is insufficient evidence that it will definitely reduce the risk of birth injuries. Next option is, we'll keep that option. Next option is the inactive labor, the RBS. Whenever the patient goes into labor, it is important that we monitor the blood glucose level every hour. And if the RBS is less than 70, if it's going as hypoglycemia, it is important we give them 5% dextrose at a rate of 100 to 150 ml per hour till the RBS reaches is 100 milligram percentage, which is a right answer. Remember, in a patient, next option is in a patient being planned for induction of labor. She has been planned for induction, so we are inducing the patient. Her night dose, if intermediate insulin is given as planned. See here, usually intermediate insulin, usual dose of intermediate insulin is given at night, and the morning dose insulin has to be stopped or withhold the morning dose and start on IV normal saline. That will be the answer. So that part of the option is wrong. That is, the morning dose of insulin is also given. That will be a wrong answer. Next is, see, once, whenever, next is regular short acting insulin IV infusion at the rate of 1.2 units per hour if the glucose level of more than 100 milligram per hour. That is one more thing you have to remember. So the answer for this is, next option is capillary blood glucose monitoring. We know the goals for that. Fasting will be less than 95, and the first hour will be less than 140, less than equal to 140, and the second hour value will be less than equal to 120. So that is a right answer. So the incorrect answer will be, see, comparing to this, though the Williams says that insufficient evidence of reducing the risk of birth injuries, but the answer here, this is a straightforward wrong answer. The third option, that is the morning insulin dose, is also given. It's a straightforward wrong answer. So the answer will be 3. That is third will be the option. So this is a very easy question, again a repeatedly asked question. What are the hematological changes under that? What are the clotting factors that decreases in pregnancy? Remember, pregnancy is a hypercoagulable state. So all the clotting factors except 11 and 13 will increase. So 11 and 13 is the answer. So answer for this will be 11. Okay, so this is easy question. Just remember all the factors increases, like except the 11 and 13. Remember, clotting factor 1 is also called the serum fibrinogen. That also increases, and all the inflammatory markers like ESR, CRP, C3, C4 levels, leukocyte alkaline phosphatase levels, everything increases. What decreases? The plasma protein level decreases, serum albumin level decreases, as obviously I've discussed. It is 11 and 13 are the only factor, clotting factor, that decreases. Protein C, protein S decreases, and the anticoagulant activity also decreases, since it is a pregnancy is a hypercoagulable state. Now coming to which is incorrect regarding the innervation of the uterus. So this question is from labor analgesia. That is mainly for, to understand better, you have to know the basics of this innervation to understand the labor analgesia. So we'll see the options. In early labor, pain is mainly because of the uterus. Second is motor innervation of the uterus is at the level of T7 to T8. This answer seems to be wrong. It's very obvious it will not be such a short for motor innervation 7 to 8. Next is sensory visceral supply of the uterus, cervix, and the upper vagina is to be the Fraunhofer plexus, that is present lateral to the cervix, and this is transmitted to the pelvic plexus and then to the superior and the midline, middle internal iliac plexus. So this is also a right answer. And in the first stage of labor, pain is due to fibers at the level of T10 to T12. This is also a right answer. The answer will be incorrect is motor innervation of the uterus. So we'll see what is it. See, first stage of labor is a visceral pain. So there is distension of the uterus. So pain is from the uterus and the cervical. When I talk about the second stage, it is a somatic pain, which is stretching of the vagina, perineum, pelvic floor, and the ligaments. So coming to the first stage of labor, as I told, it's a visceral, originate from the uterus and the cervix. It's mainly because of the distension and also because of the ischemia. Remember, the pain signal traverses here from T10 to L1. That is very important. Pain is also referred to the abdominal wall. So that's a radiating type of pain. Next is about the second stage. Here, obviously, the pain is more severe than the first stage. Here, it is it is a combination of both visceral as well as the somatic type of pain. Here, it is mainly because of a stretching effect. Here, the pain signal traverses through the pudendal nerve, so that is S2, S3, and S4. This the same option that we have discussed. This is a very old question which was used, very old question that was asked previously. Kasowitz law, which is used to describe, answer is congenital syphilis. This law states that the greater the duration between the infection of mother and the conception, the better is the outcome of the infant. So it's a very direct question, but it's the old question. The recent, okay, this is again a very difficult question, and it's a very recent advancement in an endometrial cancer. An immune checkpoint inhibitor approved by the FDA agent drug in the advanced endometrial cancer is, answer is, I'll go directly to the answer, that is pembrolizumab. So it was in the March 21, 2022, this FDA has been approved, this pembrolizumab, in the name of very commonly called as Merck, a single agent that is used in the advanced endometrial carcinoma, that is a microsatellite instability high or in a mismatch Ripper deficient, as determined by an FDA approved test. They have who have a disease progression following a prior systemic therapy in any setting and who do not are the candidates for the curative surgery or radiation. So this is a very recent advancement question. So need not have to worry about this. Not everybody knows this answer. So you have not answered this question, not to worry. It's a very recent question. It's not a very common question that you didn't answer. So it's a not to worry about this. Next question is kind of incomplete. It's only 3 options that I have got. And remember BPP, this biophysical profile, Bishop score, all these are very direct questions. So you should not afford to lose marks in this kind of questions. So what is incorrect regarding this biophysical profile? So biophysical profile, the components are the amniotic, first option, whatever they have given, that is the right answer. That is amniotic fluid volume, gross movements, fetal tone, fetal breathing, and the fetal heart rate. All these are the components of a biophysical profile. BPP correlates with both fetal pH and fetal outcome. We'll keep that option. We'll go to the next option, that is BPP of less than 4 indicates a pH of less than 7.2 and a BPP of less than 2 has a 100% sensitivity for acidemia. Remember BPP, biophysical profile of 8 or more will indicate the pH is above 7.2. Any pH less than 7.2 means it's an acidemia. BPP less than 4, it's definitely an indicator of an acidemia, that is pH of less than 7.2. And BPP less than 2 has 100%, obviously. It has a very poor, this one. What is the highest score in BPP? It is 10. The lowest can be 0. But less than 2, it's again, it has a 100% sensitivity saying it is an acidemia. So that option is right. Maybe the 4th option, I'm not aware of the 4th option, so I'm not very sure. But the 2nd option says it correlates with both fetal pH and the fetal outcome. Remember, this does not have very good sensitivity for the fetal pH, but the fetal outcome is good. You can predict the fetal outcome based on the BPP. But the fetal pH, it does not have much. So we can keep the answer as B. But the option D is important. We have to see what was the option D. Only then we can actually give the correct answer for this. So BPP, we have that Manning score. I have already mentioned what are the components of it. It mainly determines the integrity of the CNS. It determines the integrity, and fetal tone is the first to appear, that is as early as 7 weeks. That's what it says. But you start doing a biophysical profile after 30 weeks with a scores of 8 or more, mean arterial pressure will be 7.2. If you see a biophysical profile score of 8, that means the pH is more than 7.2. That is, the baby is fine and not in a acidemic state. Acidosis, when do you say acidosis? When the umbilical cord pH levels is less than 7.2. What is modified BPP? It's a very easy question. NST with the amniotic fluid index is the modified BPP. So that's all the questions that I had. I have discussed very briefly about all the questions.